Thank you for joining us for our Federal Partners webinar series in the Focus on Aging series. Today's topic is COVID-19. On behalf of our federal partners, I want to welcome you, and our federal partners logos are listed below. They are the Administration for Community Living, the Health and Human Services Office of the Assistant Secretary for Planning and Evaluation, the CDC, CMS, which is Center for Medicare and Medicaid Services, HRSA, which is Health Resources and Services Administration, the IHS, the Indian Health Service, us at the National Institute on Aging, which is part of the National Institutes of Health, and the U.S. Department of Veterans Affairs. Next slide. So the webinar overview, today's webinar will feature presentations on the following. One is going to be an overview of COVID-19 and aging generally. The next will be impact of the COVID-19 pandemic on the well-being of older adults from underserved communities. Then we'll hear about longitudinal trajectories of cognitive and functional recovery after severe COVID-19. Next, we'll hear COVID-19 and dementia, translating findings from the initial New York City wave into longitudinal studies of cognitive aging. And finally, COVID-19 and long COVID in long-term care settings. Next slide. Our illustrious speakers today, we have 5 of them. Dr. Peter Briss from the National Center for Chronic Disease Prevention and Health Promotion at the CDC. Dr. Maria Marquine from Duke University, Department of Medicine, Division of Geriatrics, Duke Center for the Study of Aging and Human Development. Next, Dr. Jennifer Frontera from the New York University Langone Health. And then Dr. James Noble from Columbia University Irving Medical Center. And finally, Dr. John Morley, Professor Emeritus from St. Louis University. Next slide. We're going to have a question and answer period at the end. As you are hearing speakers, you are invited to provide us with your questions. And the way you do that is click on the live feedback button at the bottom of the video cast page to submit that question. Next slide. And we will begin with Dr. Briss.
Good morning, everyone. I'm delighted to be here this morning, and I'll open with an overview of COVID and aging. Next slide, please. The structure of my discussion today will address several interrelated issues. So aging itself, associations of aging and chronic conditions and disability, and the impacts of adverse social determinants of health. After I tee up some issues about how all those things relate to COVID-19, we'll talk a little about how to protect yourself and others. Slide, please. So older adults are at increased risk of serious outcomes of COVID-19. Nearly 3/4 of all COVID-19 related deaths in the United States have occurred in people who are aged 65 years and older. In the US and elsewhere, older adults were a priority population for COVID-19 vaccination, but only about 40% of people aged 65 and older have had a second booster, and smaller numbers have had the brand new boosters, which were recommended in the last couple of weeks. Mortality rates have been higher in places like Hong Kong, where older adults were not prioritized for vaccination. And the risk of death among older adults who were not vaccinated can be 20 times the risk in people who were vaccinated. Just a process point, I'm going to tee up a lot of issues. And if people would like to take deeper dives into any of those, I've included footnotes that take you to more information. Slide, please. Aging is associated with chronic conditions. 60% of American adults have at least one chronic condition, and about 2 in 5 have more than one. Among people who are 65 and older, 4 people out of 5 have more than one chronic condition. Slide, please. During the COVID-19 pandemic, many chronic conditions such as heart disease, cancer, chronic lung diseases, and others were associated with increased COVID-19 related morbidity and mortality. Multiple chronic conditions were associated with higher rates of poor outcomes. Slide, please. The effects of the pandemic on people with chronic conditions were not limited to the direct effects of COVID-19. During the pandemic, the use of healthcare services declined for preventive, routine, and even emergency care. Excess mortality during the pandemic has been observed related to COVID-19, but also related to cardiovascular conditions, diabetes, and dementia, among many others. Slide, please. The implications of these effects are likely to extend into the recovery phase of the pandemic. For example, there's considerable ongoing work to address a COVID-19 related health debt that's accumulated because of less healthy behaviors and foregone medical care during the pandemic. Addressing these chronic conditions now can improve resiliency and preparedness for the next public health emergency. While we can't keep people from aging, we can do things so that they're healthy as they age. Slide, please. Next, let's talk a little about aging and disability. Some disabilities increase risk of infection or poor outcomes from COVID-19. For example, some people may be more likely to get infected or have severe illness because of underlying medical conditions, chronic congregate living settings, or systemic health and social inequities. Other disabilities may have interfered with health protection. These include challenges with accessing or processing information or accessing healthcare and other essential services. Slide, please. It's clear that during COVID-19, disability wasn't addressed early or systematically enough. Slide, please. Last, let's talk about social determinants of health. The COVID-19 pandemic underscored how differences in social and structural factors have significant impacts on health and illness. Issues like occupation, poverty, housing, personal space, places for physical activity, food and nutrition security, and healthcare, among any others, have contributed to disparities in outcomes of COVID-19. So what now? We have lots of tools to protect ourselves and our communities from severe illness. These include vaccinations, boosters, and effective treatments. CDC is continuing to streamline and simplify its guidance, acknowledging that the pandemic is not over and providing people with tools to protect themselves, but also helping us move to a point where COVID-19 no longer severely disrupts our daily lives. Slide, please. Tools to protect yourself and others include highly effective vaccines and treatments. Vaccination remains the best way to protect from severe COVID-19 hospitalization and death. And COVID-19 vaccines and boosters are safe, effective, and free. Stronger protections are necessary at high community levels and for people at higher risk of getting very sick with COVID-19. These protections include wearing high-quality masks or respirators and early access to and use of treatments quickly after infection. The next step is understanding your risk. The things we've been talking about this morning, like older age, having a disability, a weakened immune system, and certain health conditions increase a person's risk for severe illness from COVID-19 and warrant greater use of layered prevention strategies. Slide. We should protect others if we're exposed. Follow CDC's recommendations on what to do if you're exposed, including wearing a high-quality mask indoors and around others as soon as you find out that you were exposed, Get tested and watch closely for symptoms for 10 full days. Slide. Take action if you're sick to protect both yourself and the people around you. Assure early access to and appropriate use of treatments. If you have symptoms, get tested and stay home until you have your results. And if you have tested positive, follow CDC's isolation recommendations, including staying home and away from others for at least 5 days, wearing a high-quality mask when indoors and around others. Slide, please. I'll finish with a couple of resources. Search Find Help is an online library with hundreds of resources for organizations that serve older adults and their caregivers. What is Alzheimer's disease? And emergency preparedness for older adults, including COVID-19. Slide, please. Thank you very much, and I will pass the baton over.
Good morning. I'd like to start by thanking the webinar organizers for inviting me to be part of this important panel. Today, my name is Maria Marquine. I'm a faculty member and scientist in Division of Geriatrics in the Department of Medicine and the Duke Center for the Study of Aging and Human Development at Duke University School of Medicine. It's a pleasure for me to be here today, and I'm going to be sharing with you work that really was the result of a large effort by several investigators in the United States and across Latin America that came together very early on during the pandemic under the mentorship or the leadership of Dr. Jaquel Quiroz at Harvard University, who brought us together to understand, as things were happening, how the pandemic was changing the lives of middle and older age adults that are from underserved communities and often underrepresented in research. If I can have access to, thank you. Okay, so before I share my work, I'd like sorry, I'm trying, okay, thank you. Now I have access to the presentation. I apologize for that. Okay. Sorry, it's not working. Okay, I apologize for that, some technical difficulties. Okay, so before I share our work, I'd like to start by sharing some of the statistics from the CDC that show the number of the percent of cases, COVID-19 cases and deaths by racial ethnic group in people age 65 and older. So what you see represented here is the data for the older adult population in the US as of September 2nd, so just last week. And you see it broken down by the main racial ethnic groups in the United States. So if you look, for example, over here, the Hispanic Latino population, what you see represented in gray is the percent of the population age 65 and over that is Latino in the US or Hispanic. In blue, what you see are the proportion of COVID-19 cases that are from this racial ethnic group. And in red, you see the proportion of deaths attributed to COVID-19 that are members of this group. So what we see is a disproportionate impact of the COVID-19 cases and deaths in the Latino population. We see similar trends in the American Indian Alaskan Native community and the Black non-Latino community. Whether in other groups, we've seen a little bit of a less impact relative to the proportion of the population of COVID-19 cases and deaths. Another way to look at some of the data also shown by the CDC is the incident number of deaths associated with COVID-19. This is over time. So I want to point out a couple of things here. I know it's a busy slide with lots of different things, but if you look at the heart line here, those are people 75 and over, and this added kind of dashed line are people this is 74 to 75 plus and the 64 to 65 plus. So what you see in all different racial ethnic groups, a disproportionate number of deaths among the older adult population, as was previously mentioned. And the other thing that you see, or that I'd like to point out, is that certain groups, again, have these spikes that are much larger than in some other groups, again, showing how over time the number of deaths have continued to be increased in certain racial or ethnic groups. And this is still the case. So as was again mentioned in the prior presentation by Dr. Briss, the pandemic is ongoing. There's still quite a bit of impact, especially in certain groups of our population. So I would now start sharing some of the findings, again, from our group. It's a large group, and these were published last year, some of the things I'm going to be sharing with you. We're able to recruit a group of close to 900 community-dwelling adults age 50 plus that were living in the United States. As I mentioned before, we also included a number of countries in Latin America, and I'll show you some of the data towards the end, but I'll focus my presentation on the US sample. So we had primarily three members of three ethnic racial groups: white, Hispanics, and Blacks. And you see that mean age was around 65, pretty well-educated group, which is limitation of our findings, something to keep in mind. And as it's not completely representative of the overall population, and mostly female. So our participants in this study completed a survey either online or via phone between May and September of 2020. So this was, very early on in the pandemic, where, there was a lot of uncertainty. Of course, there still is a lot of unanswered questions, especially at that time. A lot of things were closed down at that point. Participants completed this survey that asked for a number of different, included a number of different measures having to do with well-being and the impact on people's lives. I'm going to focus on two main measures that we gather. One was of the impact of the pandemic on several aspects of life via the Epidemic Pandemic Impact Inventory, and also the report of cognitive symptoms or cognitive problems at that time relatively to before the pandemic. So what you see represented here are findings from the subscale that assessed infection history or potential infection history. Back then it was also hard sometimes to get access to testing, especially in certain populations and so forth. I'll show in the next few slides similar graphs as this one for different domains of life and impact of the pandemic on life. In gray, you would see represented the non-Latino, non-Hispanic white group, in red, the Hispanic Latino group, and in green, non-Hispanic Blacks. And this refers to their infection history. These are the items included in this scale. So, which, are basically having symptoms of the disease, having been tested, thinking that you might have the disease. This early on, again, in our sample, we already saw that Hispanics, Latinos tend to fare worse on infection history compared to non-Latino whites, and a trend in Blacks as well. When it came to the economic impact of the pandemic at that point in time, we also saw that there was more financial hardship among Hispanic Latinos than non-Hispanic whites and Blacks, as assessed by the subscale, including these items here, as you see listed, like an inability to get enough food or healthy food, access clean water, etc. So Latinos in our group were reporting having more trouble with this, having a greater economic impact at the time. We also, sorry, this is freezing up and I cannot advance. It's not letting me advance. I'm not sure if IT wants to take control and advance the slides.
I need 10 seconds. I'm sorry about that.
No problem. I'm sorry to the audience about it. Hopefully we'll get going fairly soon. So as the technical difficulties are being sorted out, I think, overall, some of our slides, what are showing at this point is this disproportionate impact of the pandemic in the lives of people from underrepresented minoritized groups in the US. So, we know that the pandemic impacted, basically the life of everyone. in one way or another, but this impact has been disproportionate in certain groups, and the sociocultural context is important to keep in mind as we evaluate what has been the impact of the pandemic and what might continue to be in the future. Okay, so I think now I should have access again. Let me see. Okay, I do. Thank you for that. So we were here in the economic impact. I'll move forward to the next one. So another scale evaluated the impact of the pandemic on people's home life. And again, you see the items in the scale represented here to give you a sense of how this was assessed. So, there's very different in many ways, but some of the things we saw the most noted were increasing verbal arguments, physical conflicts with spouses, partners, other people in the home. And what we saw for this scale is that among non-Latino and non-Hispanic Blacks, these changes in home life, negative changes in home life, happened more often or more frequently than for other groups. Here, the scale assessed the limitations in social activities and having to distance physically, which was quite prevalent at that point. There were no significant group differences, but everybody was having to do that quite a bit at that time. Then in emotional health, we didn't see significant differences across groups, but we did see that a lot of people were endorsing important changes in emotional health, both of themselves and people living with them, increasing mental health problems, increasing sleep problems, alcohol or substance use. So quite notable. Then same thing for physical health, no significant group differences, but still notable changes noted across many different segments of the population, as listed here, like increasing health problems not related to the disease, less physical activity, etc. This slide I'd like to spend a little bit more time on. So what I've been discussing up until now are, mostly captured under the umbrella of negative impacts on daily life of people. Now, what this subscale assessed was positive life changes associated with the pandemic, like, as you see listed there, more quality time with family members or friends, and children or spouses, improved relationships, more time in nature, and so forth. What we saw was that both for the Hispanic Latinos and non-Latino Blacks in our samples, these groups reported more positive change associated with the pandemic, which is somewhat striking given that either Latinos or Blacks were seeing a lot of other impacts of the pandemic that were negative. So this was some positive things that were noted. As I mentioned briefly before, we also assessed cognitive symptoms, self-report of cognitive symptoms in this case, so people reporting problems with memory, thinking, and other processing speed, other skills. We saw that actually non-Latino whites reported more cognitive symptoms than both Hispanic Latinos and Blacks, and greater negative impact of the pandemic was associated with more cognitive symptoms across groups. So basically, the more negative life changes, the more that people were noticing cognitive changes or changes in thinking or memory, which can be, in some cases, a precursor for more important problems like Alzheimer's disease. I'm going to share very briefly some of our results of our Latin American sample, which is, the demographics are depicted here. So again, there are people 50 plus, mean age of 65, quite diverse in terms of gender, but primarily female. You see some of the statistics listed there. It included a number of countries in South America, Central America, and the Caribbean. And the main reason why I'm kind of giving you a glimpse of this sample, these findings were presented at the Alzheimer's Association International Conference, is that we looked at the data in a somewhat different way, investigating what was both the negative and positive, how did both negative and positive life changes impact cognitive symptoms in this older sample. What we saw is that, similar to what we had seen in our US sample, more negative life changes were associated with more cognitive symptoms or more cognitive problems. However, this association was much weaker in people that reported at least one positive thing associated with the current pandemic, suggesting that being able to experience at least one positive change can significantly buffer the negative impact of negative things happening in your life with the onset of cognitive problems. So to conclude, we observe racial ethnic differences on the impact of COVID-19 pandemic in our US sample in the lives of people, with usually minoritized group presenting with a more increased negative impact of the pandemic on their lives. But despite this, these groups also reported, were more likely to report positive life changes associated with the pandemic as well. While more negative life changes related to more cognitive symptoms, this association was considerably less strong in people with positive life changes that were able to report. So our studies, of course, have some limitations. Like, this is not a population-based study. It's a sample of what we call a sample of convenience. And we, at this point, have self-reported cognitive symptoms. Some of the future directions that we are exploring right now are to examine the long-term impact of the pandemic on well-being and cognition. This is an ongoing study, so we'll be able to look over time how things have changed in terms of how those early impacts of the pandemic impacted cognition down the line, and we're including performance-based objective measures of cognition in a subset of the sample. So with that, I'd like to wrap up by thanking you for being part of this, and the international group of investigators that's very large, and our funders, the Massachusetts General Hospital Executive Committee on Research, a philanthropic gift to the University of California, San Diego, where I was when I conducted this work, and also the Plan y Vida Pita in Uruguay, one of the countries included, that I led the arm there and supported our studies. So thank you so much, and to that, I'll leave it up to the next presenter.
Okay, great. Thank you. And I think I have control, I believe. My name is Jennifer Frontera, and I am a neurologist. I specialize in stroke and neurocritical care. And I also work closely with our Alzheimer's Disease Research Center at NYU on COVID-related cognition. Let's see if I can advance my slides. Okay, I am battling someone else with the mouse bit. Okay, these are some disclosures. I have a variety of grants from different NIH institutions related to COVID, and I also sit on the WHO Brain Health Task Force for COVID-19. Okay, thank you. I think I have control now, thank you. So I'm gonna start off talking about some of the studies we've done at NYU. And again, there's an immense literature now at this point looking at neurological events following COVID, way too much to discuss in one brief talk. So I'm just gonna focus on some of the work that we have done. So during the first wave of COVID in New York City, we were able to organize a prospective study where we looked at patients that were hospitalized between March and May at our hospitals. And we basically looked through everyone that was touched by a neurology team and identified patients that had new neurological events related to their COVID admission. And then we followed these folks out at 6 and 12 months and made phone calls to do a variety of different batteries, checking their functional status and cognitive status, as well as neuropsychiatric functioning. So we initially enrolled about 4,500 patients during this 2-month epic, and we identified about 14% that had a new neurological diagnosis during their hospitalization, and compared them to 3,885 that did not. We then looked at survivors and propensity scored matched them, and you can see this is roughly the number of patients that we followed over time. We had about 382 at 6 months, 242 at 12 months, and a total of 481 unique patients at either of those time points. And so what we found during hospitalization was that, the most common event was really what we call toxic metabolic encephalopathy, which effectively means confusion. And we looked at patients who were not confused because they were getting sedation. They were confused because they had some form of brain injury, either due to an infection, low oxygen levels, kidney failure, et cetera. And this was by far the most common thing that we observed, and has subsequently been observed in multiple other cohorts. We also saw ischemic stroke, hemorrhages, seizures, and a variety of other things, but mostly dominated by this encephalopathy or this mental status abnormalities. Most of these people develop these acutely within a couple of days of initial COVID symptoms. And people that did have a new neurological event, unfortunately had a much higher rate of in-hospital death, which was increased by 38% compared to those who did not. During this initial hospitalization, we also looked at some blood markers of brain injury. And we used single molecular array technology to look at these markers. Tau, UCHL1 are markers of neuronal injury, as is p-tau 181. This phosphorylated tau is more specific to Alzheimer's type pathology. GFAP is a marker of glial cells or astrocytes, and NFL is a marker of axons or axonal injury. And what you can see here is people that had toxic metabolic encephalopathy or changes in their mental status had significantly higher levels of many of these markers, as did folks who died in hospital. And those who were able to go home had significantly lower levels. Sorry, just trying to advance. We also compared levels of biomarkers to our Alzheimer's disease cohort who had donated blood samples in 2019. So definitely were COVID negative and who had been diagnosed with either mild cognitive impairment or Alzheimer's type dementia. And for some of these markers, you can see that the levels were as high as, if not significantly higher than what was observed in Alzheimer's type patients, indicating that we were looking at people with a pretty severe brain injury. And I also do want to mention that when we evaluated the COVID patients, we excluded people who had prior history of dementia or cognitive disorder. So we really wanted to get a sense of acute injury happening during that hospitalization. So we followed these folks out at 6 and 12 months to see what their outcomes were. And here's a variety of scales that we kind of measured. Modified Rankin looks at, do you still have symptoms? Can you do your normal activities? Can you walk? Are you bedbound, et cetera? And higher scores are worse. Barthel Index is activities of daily living. Can you go to the bathroom by yourself, shower, comb your hair, get dressed, et cetera? Telephone MoCA is a cognitive score. It's a global, pretty basic global measure of cognition. And then we also looked at these self-reported outcomes here. And, I'll just draw your attention to, overall the fact that 90% of people had at least one abnormal metric at 6 months, and still 87% had at least one abnormal metric at 12 months. And if you look at the telephone MoCA scores, because we're focusing on cognition here, 49% of people tested abnormal at 6 months, 41% at 12 months. And this is excluding people who had baseline dementia or cognitive diagnoses. And this is adjusted for educational status. So somewhat profound cognitive issues, even out to 12 months. The good news, however, was that between 6 and 12-month testing, we did see significant improvements in telephone MoCA scores, as well as anxiety scores. And, there was generally improvement in the majority of folks for fatigue, sleep depression, self-reported outcomes. Functional status and activity of daily living actually tended to remain static and plateaued for most folks, which is not unexpected since most people typically make their maximal spontaneous recovery within 3 to 6 months after neurologic injury and then plateau. What we're interested in now, I think, is these red bars of folks who seem to continue to get worse over time. And so what is different about these patients and what can we do to intervene is, I think, an important area of focus right now. We also looked at subjective symptoms. 50% of people said they still had symptoms at 12 months. And this is the WHO checklist for symptoms. So there's a lot of stuff covered here, but you can notice shortness of breath, headache, and brain fog were the most common. Brain fog was reported in 20% of people. And overall, still 71% of people reported multiple symptoms. So most people have more than one. But just to remind folks that symptoms are not the same as signs or standardized testing. So if you were especially attentive, you might have noticed that 40% of people tested abnormal on a telephone mocha, but only 20% said they had brain fog. So there's definitely a disconnect. And in fact, some folks may not recognize that they have a deficit, which is not uncommon amongst dementia patients or people that have cognitive issues. I will say we did not have baseline cognitive testing prior to COVID, so that's a huge limitation. But there probably is a suggestion of this year. And this is important because in designing studies, we can't just enroll patients that happen to say they have symptoms. There has to be other criteria for enrollment because some people may not recognize deficits, and still those are folks that really need to be included in studies. These symptoms that people had were important, okay? And 45% of people said they couldn't work to the degree they had prior to being hospitalized for COVID. They couldn't do household responsibilities or leisure activities. And this week, there was a report from the Brookings Institute estimating that 16 million Americans have long COVID. And then 2 to 4 million of these may be unable to work due to long COVID. And this would translate into annual lost wages of $170 to $230 billion each year. So that's a substantial impact. And I think long COVID is going to be with us for a while as an area of interest for study. Now, I mentioned that 70% of people, at least in our cohort, had a lot of different symptoms. Is everybody with long COVID the same? No. And I think, we did a hierarchical cluster analysis, unsupervised statistical analysis, trying to group these folks together to see if there's different types of people with long COVID. We came up with 3 groups, one with, few symptoms, one with a handful of symptoms, and then one with a lot of symptoms. The first group, not too much going on. They complained of headache primarily. The second group was a little over half of people. They had usually about 3 symptoms. Shortness of breath, headache, and brain fog were most common. And then there was a minority of patients that had multiple symptoms, a median of 16 different symptoms. This group had prominent anxiety and depression. They had a greater number of life stressors, which is related somewhat to the last talk. And they were sicker. They were more often mechanically ventilated during their index hospitalization. We also looked at therapeutic interventions that were applied to these clusters. And, not surprisingly, patients with few symptoms were less likely to receive interventions, but a substantial proportion did improve with whatever they received. In the middle group, PT, physical and occupational therapy were common, and a lot of people improved. And in this last group, which is the sickest group, not just by symptoms, but they also had worse functional modified Rankin scores, and then worse reported metrics for anxiety, depression, fatigue, and sleep. These folks were more likely to receive some sort of psychiatric treatment, whether it was talk therapy or medical intervention. And fortunately, 100% reported some degree of improvement. Now, this is a small N, it's only 122 people, but I want to bring this to light just because I think it's important to take a holistic approach with these folks and recognize that not every post-COVID patient is the same, and that neuropsychiatric interventions should be considered and applied as appropriate in sort of a holistic approach for these folks. We also looked at predictors of objective and subjective outcomes, and really there were 5 main ones that came up. These have been sort of seen in different cohorts as well as ours. Not surprisingly, older folks had worse functional outcomes, activities of daily living, worse cognitive status, and higher rates of depression, subjective depression. Female sex was associated with worse activities of daily living and anxiety scores. Baseline disability was, if you're disabled at baseline, you were even more disabled afterwards, which is kind of intuitive. And then life stressors, what we looked at were 13 different stressors, similar to what Dr. Marquine was discussing. We looked at financial insecurity, food insecurity, social isolation, relationship difficulties at home, education disruption, domestic violence, et cetera. And these stressors actually had higher odds ratios or adjusted odds ratios for predicting worse outcomes than almost any of these other predictors that I'm showing you here. And this was across a spectrum of different outcomes, including subjective symptoms. COVID severity, as in many cohorts, also affects your development of post-acute symptoms and activities of daily living. Our cohort, some might consider all of them to be severe because they're all hospitalized. But when we say severity here, we're talking about requiring mechanical ventilation. But certainly COVID severity is a driver of post-acute sequelae. Last, I'm just going to show you this. This is a heat map. Don't look at the numbers, but this is looking at those same Simoa biomarkers I showed you earlier. And the green means that there's a strong association or significant association. And so you can see some of these biomarkers do light up in terms of matching up with outcomes at 6 months and 12 months. And this is a very small sample size, so you have to take this with a little bit of a grain of salt. But we did find that NFL was associated with significantly higher risk of death or severe disability after adjusting for other factors. And that's kind of interesting because we're all in search of a brain troponin. And there's other studies also suggesting that NFL might be a good biomarker. And lastly, I'm just going to say we have a few studies going on now. We have an R01 that I am participating in as a PI with people at our ADRC, Dr. Wisniewski, and our neuroradiology group with Dr. G. We're particularly looking at kind of applying the viral theory of Alzheimer's to post-COVID and looking at how hypoxia, low oxygen levels, inflammation can contribute to a cascade of injury that could lead to buildup of amyloid beta and neurofibrillary tangles in the brain.
Dr. Frontera, I think we're going to need to move to your last slide.
Okay, sure. And I'll just skip quickly through this, but if anyone's interested, we do have an NINDS funded data biobank where we're looking at acute and post-acute neurological outcomes. And then of course there's a Recover project, which is a large $1.2 billion project looking at post-COVID across the life spectrum. And so just to wrap up, there's a concern about neurodegeneration and acute biomarkers in the acute phase. And we still see a lot of disability even out to 6 and 12 months in these folks, though there is some improvement in cognitive scores over time. Life stressors are really important, as are some of the other predictors that we expect, but they should be considered and addressed. And there's some ongoing studies that are supported by the NIH that hopefully will help us disentangle what's happening with post-COVID. And I'd like to thank a huge team that supported this work and thank everybody for their time.
Okay. Thank you, Dr. Frontera. So I think, do I have control of the screen now? Okay, very good. Thank you. Hi, my name is Dr. James Noble. I'm a neurologist here at Columbia University Irving Medical Center. I'm the clinical core leader of our Alzheimer's Disease Research Center and focus primarily on cognitive disorders of aging. I'm going to be presenting today to you some of the things that are really serving complement to the prior speakers and trying to share with you what we learned as we were really in the midst of the maelstrom that was the COVID first wave. And translating those findings into now what we are really interested in, which are longitudinal studies of cognitive aging. What does it mean to have had COVID, both in the initial waves and subsequent times? So I want to thank the organizers and the support that I've received previously. Here are my disclosures. The primary related ones are the NIH grant support that I received, which in part has funded some of this work. Today, we're going to be reviewing, as I said, the experiences we had at our center, the epidemiology of dementia related to COVID symptoms and mortality that we found at our center during the first New York City wave, and how we've thought about that as evolving concepts and complications have emerged, including long COVID, but also balancing that against new treatments and vaccination strategies that have emerged simultaneously. And also, how do we put all of that together and begin to leverage what existing studies we have to better understand the impacts of COVID on aging populations, especially those who are at risk of or who already have dementia and other cognitive disorders. So just to reflect on, where we got started, it's hard to believe that just 2.5 years ago, the world was so different, but it was. And at the time, just before the pandemic hit, we in our practice had 13 clinicians, including 8 faculty, 3 fellows, and a nurse practitioner. And that has largely been our setup ever since. And our practice is very large. We see somewhere between 800 and 1,000 new individuals with cognitive concerns and 2,000 to 3,000 follow-ups annually. We serve primarily the residents of Northern Manhattan, including Washington Heights and the Southwest Bronx. And we have also a large referral basis from the tri-state area. And we were entirely in person through February 2020. We also have at our center the benefit of a large research portfolio trying to help us understand normal cognitive aging, both in community cohorts as well as those persons who are affected by dementia and enrolled in large trials. And we are also supported by a program called the Center for Excellence in Alzheimer's Disease, which is a state-supported program, which is relatively agnostic to insurance status and trying to serve those communities as best as we can, and not just patients, but also to educate other caregivers and clinicians in the community. And just to reflect on the specific experience of New York, here we are with the waves, as have been seen many times. These are from the Johns Hopkins dashboards that are currently available and we're probably all familiar with. But just to kind of reflect on what New York's experience was, we were really in the center of a lot of emerging and new concerning data. We're very concerned about what our patients' well-being was. And this really began in early March. And that also, I want to put in context to the remainder of the United States, which has really helped us think about nationally when we think about Alzheimer's research strategies on a national level, that what fits for New York does not fit for everybody else. The timing of what we experienced was very different than what the remainder of the country experienced, and often we were kind of the leading edge of those things. Back in March 2nd, 2020, we had the first case that was hospitalized at Columbia. I think the first case that was diagnosed was a day or two before at another center, but we had the first hospitalized patient here. And within 2 weeks, everything basically shut down. Schools were closed, outpatient procedures stopped. All of our research really came to a halt. The next step we had about 3 months later, some research resumed, primarily remote, but some in-person work. Schools reopened 6 months later on a delayed timeline. And then we began to have the vaccinations available by really just before mid-December in 2020. Again, the timeline in the remainder of the country was quite different. There were lags with first waves and second waves looking very different than what we experienced in New York. And just to give you a sense, these are different scales here, but the relative waves are important to understand that not everything lined up. And as has been shared from some of the other investigators here today, we really had 2 kind of calls that we've received in our practice, which have evolved into kind of our own research experience and the interest that we had. One was that we were seeing delirium in persons with possible COVID symptoms at a time when it was very difficult to get a test, and families were fearful of coming to hospitals because of really dissociation, so they were unable to see their family members when hospitalized. And also with lockdown policies, families were facing new caregiver roles, distress, and it was just not all about the illness of COVID, but everything else that went along with it. And so our research questions at first were really, is delirium an unrecognized symptom in COVID? And is COVID more deadly also to our patients with dementia? This was a very serious concern, still remains a serious concern. And again, we had these reluctances, these challenges that we were facing in counseling our families. And we also began to wonder, what are the impacts of this on our caregiving and what were the long-term sequelae? Even before we were thinking about post-COVID syndrome, we were worried about, what are the long-term impacts of this problem on brain health. And like Dr. Frontera, we took a look at our inpatient population, and we were able to look at all cases age 65 and up between March and April of 2020, and published this with a group of colleagues in Journal of Alzheimer's Disease in May of 2021. And what we found basically was that for the most part, the symptoms that we saw in older individuals with or without dementia were largely the same that we saw with the general population, with cough and fever being very common. But we saw some things that were less common, like dyspnea, diarrhea, muscle pains, chills. And we also saw that this altered mental status or confusion was very common, suggesting that there is delirium associated with COVID, as we were suspecting, but perhaps an underreporting, perhaps related to those who had dementia not being aware of their symptoms or not remembering to report their symptoms, or maybe a different experience altogether. So we found that persons with dementia were 3 times more likely to present with delirium, but they less often presented with other COVID symptoms. And dementia was associated with a higher mortality, but not after taking into account other comorbidities and age. code status was also strongly associated with mortality, but did not significantly attenuate our other predictors. And so the limitations we recognized, it was a single center, it was a retrospective chart analysis, and there's the possible bias of reporting or forgetting. And the first COVID wave, we started seeing that there were dramatic differences in resources, care, and obviously since then, vaccines and variants have come along. And so we started to wonder, were findings, by the time we were really assimilating a lot of that information, were the findings that we had in the first New York City wave really relevant to the next New York City wave? And how did they relate to the first true wave across the United States? So there have been, a lot of concepts around COVID-19 that we've been thinking about and experiencing ourselves. As we all know, there are different variants, so many variations to the pandemic. We've had new variants of the disease itself, new complications, new recovery pathways, and a lot of these have been reflected either through the course of either natural immunity through exposure and illness, but also new treatments and new vaccines that have come along. And even just this week, the new booster is rolling out. We've also had different timing, as I've mentioned several times already, between our area and other localities, as well as the nation's experience with it. And as I said before, there are co-occurring factors, not just the psychosocial distress of the pandemic and the initial lockdowns associated with it, but other unique social stressors occurring in parallel throughout the United States. And so what we really started to understand is we need to understand the impact of COVID on a large scale amidst so many changes in disease, heterogeneous experiences, and whenever possible, leverage existing large studies of aging to help us identify the trajectories. So as the clinical core leader of our Alzheimer's Center, I see no better opportunity than really our experience with the ADRCs, the National Alzheimer's Coordinating Center. There are now about 40 centers nationwide, following about 45,000 participants over time. Some of them have not been seen for a long while, but many are still actively being followed. And basically everybody in this cohort at these different centers is seen annually. Almost all are age 60 and above, and most are older than that. And we see a range of cognitive diagnoses from normal to persons with dementia. And many centers, but not all, bank blood work and data for genetics and imaging. And COVID, we began assessing its impact within this cohort back in June of 2020. But that form that we used was at a time before post-COVID syndrome had been described and before all of the major psychosocial distressors had really become apparent within the population. And before we really had recognition of recurring infections with COVID, before vaccines and treatments. And we started realizing that, this pandemic clearly was not going to resolve within a year, but that was how the form was largely constructed at the time. Those are the presumptions. And so here's what we looked at. We actually took an early look at basically the first year's worth of experience with this form. And that first year really predates most of the cases within the United States, but it was telling what we did learn. This is actually this graphic at the right. It was really more closer to 3,500 forms that were completed over the course of about a year and a half, but largely what we saw in the first year. And that is that we saw far more people being tested than were sick. We saw a relatively small number of individuals who were hospitalized with COVID and then came back to be seen. We saw a lot of people who had cognitive changes. So again, this is something that's happening in parallel to cognitive aging, but also the other distressors that are happening within the person's lives. We also recognize that, as this form was rolling out, we, instead of that 1 year kind of time-locked assessment, we wanted to better understand what were the summative experiences of persons for what was really a brief illness for most, potentially recurring for some, and all the while a rapidly evolving problem across the United States. So I've been co-leading an initiative with several others at other ADRCs to rethink and actually redeploy a new COVID impact form, recognizing in the meanwhile, as Dr. Frontera said, that we have had myriad studies that have supported that it seems to be that COVID-19 for some serves as an inflection point for clinical decline. And there are some studies that have suggested, in addition to Dr. Frontera's, that plasma biomarkers and MRI changes evolve relative to somebody's experience with COVID-19. We really have an unmatched opportunity for study across these 40 centers between not just having a nationwide study, but a representative study for many who are underrepresented in research. And we really have primary goals of this updated form to capture information to inform key scientific questions really about the biological impact of COVID-19. Both the immediate and long-term sequelae, reflecting on treatments that have evolved over that time, the impact of vaccination, and understanding that the timing and type of vaccination and the timing of infection may also matter. And to that point, we're going to try to capture not the strains necessarily, because people don't often know, but the timing of their infection can inform maybe what strain or what severity they may have experienced, in addition to the level of care that they received. And this is used in conjunction really to dovetail in with other experiences that we have ongoing in the NAC and the National Alzheimer's Coordinating Center to further understand not just the clinical burden and neuropsychological impacts, but understand what healthcare utilization took place over that same time. So this is a work in progress. We hope to be able to report out some findings within the next year or so about what that summative experience was within this cohort, and I look forward to sharing it potentially with you then. If you have any questions, please feel free to reach out.
Thank you, James. I'm going to talk about the impact of COVID, both on nursing homes, but also long-term care settings. There'll be some overlap. My one major conflict of interest that I'm still doing in my retirement is we're developing computerized programs for older people to do good evaluations as opposed to what tends to happen. I want to point out that all the rapid screens that we've developed at St. Louis University are in the public domain and can be used by anyone. There is no cost to them, which is important. And the next slide, if somebody, because I can't get my slides to go forward. Okay, so this is long COVID syndrome. Here is a Native American woman saying, seems like it's been a long journey in the last 2 months of recovery. I'm making progress and starting to walk independently with a cane, a little at a time, but getting there. When we look at COVID-19 and mortality, we have to realize that the United States has done pretty terribly, as has UK, Italy, and obviously some of the South America countries compared to others. Would like to stress that if you look at Singapore and Taiwan, where fundamentally utilization of masks is a normal behavior when they have infections in the community, have done remarkably well. And I will keep on pointing out that the science truly confirms that the use of masks is important and most probably as important as vaccines. So I need to say this because we've moved into an era where people don't seem to think masks are that important. As has been pointed out by others, the people who tend to die are the older people. When we look at COVID-19 in nursing homes, many nursing homes have had multiple outbreaks, weeks of sustained transmission over the period of time. And some nursing homes are up to their 4th outbreak at this stage, and some of these outbreaks are short, some of them are long. And this slide shows what I think we all know, that COVID comes in sort of bursts, that when you have these bursts, deaths tend to go up. The most recent burst, which has been taking place towards the end of August, beginning of September, appears to be associated with less deaths than the others. This is particularly true in nursing homes, where we have had much more vaccinations. So if you look at it in the nursing homes, basically the CDC and CMS said that we needed to get everybody vaccinated. And we got about 87% of residents vaccinated with their primary vaccination. But at the moment, only 56% of residents are updated. This is a problem. If you don't get the boosters, it appears that the vaccination is a little bit like the flu vaccination. It works for a short period of time and then it disappears. The other problem is staff, originally well vaccinated, but staff are not following up with vaccinations. And when we look at the confirmed cases, we have over 1 million confirmed resident cases of COVID, with about 155,000 deaths, and staff also very high numbers, though much lower death rate within the staff. Put this in because I think this says what I want to say. I have, as far as I know, not had COVID. I've been fully vaccinated, but also my wife and I wear masks whenever we go out in public. And my dogs, I haven't managed to mask yet, but when I walk the dogs, I also wear a mask. So I think it's really important to realize that the masks are important. We know that this is a disease that is airborne and aerosol sent out. And we also know that the N95 is better than the average surgical mask, though I think that any sort of mask is better than none. We also have to recognize that with lockdown in the nursing homes, a lot of the nursing homes have slowly moved towards telehealth. And I think eventually we will have a high quality of telehealth, which will improve care in the nursing homes. How well telehealth is done over the COVID period, we don't really know. The diagnosis of COVID, which in nursing homes is done regularly because of the requirement, the PCR is 97% accurate. It doesn't do a good job in the first 2 days, and it detects those who are infected. Antibodies, IgA stays up longer than IgM and detects those who have had disease. So if we look at nursing home medicines, the worst example I can find as a picture is from the Spanish army who went to caregiver, where they found went into a care home where they found most of the residents were dead and abandoned. It's important to recognize that many persons in nursing homes are positive without symptoms, so regular treatment, looking for symptoms is important, the testing, and the existence of personal protective equipment is very important. I strongly feel that we should not take untested hospital patients. The hospital should test before they are sent to the nursing home. And within the nursing home, if people are sick, you need to have isolation, which is a problem, seeing often people share rooms, and that requires how do you treat the person who is not infected with the person while you make sure that they're not going to get infected. Obviously, why nursing homes do so poorly is these are a very vulnerable population and large amounts of interaction amongst the population. So when we look at rehabilitation and long COVID, post-COVID conditions may also be known as long COVID, long-haul COVID, post-acute COVID, long-term effects of COVID or chronic COVID. They are diagnosed when symptoms have been present for 3 months after acute event. They're present in somewhere between 5 to 45% in a noticeable form, but as we've seen from some of the talks, 60% of people may still have some symptoms a year after their COVID. When it involves the brain, this is myalgic encephalomyelitis, and if we look here, patients reporting COVID symptoms can be really by 18 months, still 15% of people have them. What are these symptoms? We've heard about some of them. Obviously, confusion, either as delirium or dementia, worsening dementia. Fatigue is a big one. Headaches a big one. Always look at the eyes. They can be red. Anorexia can occur. Dyspnea we've heard about. Cough. Loss of taste and smell are important and don't go away necessarily. Chest pain often remains. Some kidney failure. Autonomic neuropathy, including POTS, is not uncommon in many of these patients and is not well looked for. People have joint pains and myalgia. Sarcopenia and cachexia due to loss of muscle is fairly common, and falls increase. These are persistent symptoms we have to look for. The best example of this that I know was a picture for the Boston Red Sox, Eduardo Rodriguez, who took over a year to recover from his long COVID symptoms and had to sit out the season for playing for the Red Sox last year. Cardiopulmonary effects. We know that lots of people with COVID actually have what appears to be pulmonary emboli with need to measure D-dimer, use Doppler ultrasonography, lung diffusion, and VQ scans. Important to recognize this pulmonary embolism in long COVID appears to be peripheral, not central. Myocarditis, extraordinarily common. Myocardial disease can go on for a year or so after long COVID, maybe not recover. You need to avoid QTC, prolonging drugs, and NSAIDs, and arrhythmias are not unusual. The post-inflammatory lung damage, which causes the dyspnea, we need to do lung function tests. If people are breathless, we need breathing exercises and home pulse oximetry. Methacholine challenge, the cough variant, and asthma is common and may not be picked up any other way. And pulmonary rehabilitation needs to be done and has not been done well at this moment in time in many people who have got long COVID. The 6-minute walk test was not done in the majority of patients, but when done, it tends to have poor outcomes earlier. Stimulation therapy for anosmia and dysgeusia can be done the same way it's done for other causes of anosmia and dysgeusia, and you can get about 2 out of 3 people post-infectious and 1 out of 3 people post-traumatic who improve that space before COVID, most probably the same with COVID. Fatigue is an important component of COVID. Sarcopenia goes along with the fatigue, weight loss, dysphoria, depression, anxiety, the post-trauma syndrome, sleep apnea. Always look for it in these patients, and physical frailty. You can use the frail test for that. The treatment includes graded exercise, leucine-enriched amino acids, supports and psychological therapy. Refer to a psychiatrist if the PHQ-9 is greater than 15, and a nocturnal pulse-ox if positive CPAP. Brain fog, we've heard lots about, and we have to recognize the slums is free, by the way. It's not copyright and works as well as the MOCA. Both work better than the mini mental status. You need to look at doing brain stimulation games, cognitive stimulation therapy, exercise, and exclude depression and sleep apnea. The pathophysiology of long COVID is mostly related to pro-inflammatory cytokines. These have been shown to destroy and damage endothelial cells, which can lead to problems within the brain as well as throughout the body. They also lead to cachexia, and they lead to a thick alveolar producing dyspnea. The effects on the heart include chest pain, dyspnea, and the autonomic dysfunction. Long COVID is not new in the sense of the disease syndrome. Post-viral syndrome, which I first saw nearly 50 years ago as an intern in South Africa, Epstein-Barr virus at that time. But any of the viral diseases do this, and it's important to recognize this. There are a number of things you can measure, like the D-dimer and the ESR, which were elevated and help you a little bit, but we have to recognize this. Social isolation, or the loneliness epidemic, is extraordinarily common in older people. And in our nursing home, before the epidemic, we had 20% of people in academic nursing home who had loneliness. This was in a nursing home with a huge amount of activity, and that was the thing we pushed in the nursing home. Post-COVID, this has gone up quite a bit. As Ernest Hemingway said, no one should be alone in old age, but often it appears to be unavoidable. And with the lockdown, we certainly ran into this in a big way in our nursing homes. So to conclude, I should point out that great paper by Janice Sorensen in JAGS, a call to action to understand, enhance understanding of long COVID in long-term care of our home residents. We make a call to action to the research community to rapidly address the dearth of research about long COVID among residents in long-term care homes. The knowledge gaps and challenges outlined above emphasize the need for research to inform guidelines for long COVID management and its unique context. And long COVID still has a long way to go for patients and clinicians. And every time I hear some politician or doctor telling us that fundamentally COVID pandemic is over and we do not wear masks if we don't want to, and lots of people don't seem to want to get vaccinated, I realize that we have a long way to go. And I think it's extremely important as a geriatrician that we continue to point out how important it is for people to do the basic things, vaccinations and masks. Thank you all very much.
Thank you so much. I want to thank all of our speakers. Everyone had a lot of very helpful information to share. I want to thank our audience. We got a lot of questions. We'll do our best to get to as many of them as we can. So the first one I think this is probably for Dr. Briss. How soon after your last booster should you get the new booster for the more recent variants?
Anytime that you're at least 2 months out from your previous. Once you finish the primary series, anytime 2 months after your last shot, you can get the new booster, and this applies to the boosters are available for everybody ages 12 and over.
Thank you. And our next question for Dr. Marquine. Does being aware of the negative impact of the pandemic positively improve outcomes for Hispanic, Latino, and non-Hispanic Black individuals? And could that explain the increased positive impacts on these two groups?
Yeah, so very good question. I don't think we have a straight answer to that. I think it's important to keep in mind that of course, this is also report data. So this is the perception of people of what's happening to them and what has happened and how their lives have changed. So I don't think our data can directly answer that question. I do think it's important. It's important to recognize that, again, it's people's perceptions of the events that are happening in their lives. We're not kind of videotaping their lives and knowing. So it's a key thing to consider as we think about how this data might inform future potentially intervention efforts or prevention efforts for further cognitive symptoms. I hope that helps answer.
Thank you very much. I think Dr. Frontera is working on her video, so I'm going to ask a question for Dr. Noble. Does the research team believe that the SARS-CoV-2 virus increases delirium or triggers a separate pathway in individuals with dementia that leads to delirium as a symptom?
That's a great question. I don't think we fully understand it. I think the way that we've tried to approach it is that we see delirium as a common manifestation in individuals who have dementia, no matter the cause of illness. We see this in people who have urinary tract infections, pneumonias, or fevers for other reasons. And I'm not so sure that that COVID is necessarily distinct from those other pathways. It may be. The way that we've kind of conceptualized it is that it seems as though COVID is somewhat distinct in that its inflammatory state is intensely active in its immediate phase, perhaps to a greater extent than we've seen in those other more traditional infections that we see in dementia. And that provides us a model of thinking about it from a biological pathway. It's also made us wonder is, since it is such a common problem that so many people have faced, probably more common than things like urinary tract infections or pneumonias that we see more in the later stages of disease, does COVID present an opportunity for us to think about how inflammation in the body impacts the expression of dementia, recognizing that our traditional models have been a low-grade infection over many years of time, or low-grade degree of inflammation, I should say, over a long period of time that we see in things like people who have diabetes or obesity or smoking or sedentary lifestyle. Is COVID in some respects similar to that, but an intense high degree of inflammation over a brief period of time relative to those other traditional risk factors, which may have a low degree of inflammation to a low degree over many years of time, perhaps even preceding the first stages of dementia. And from a conceptual standpoint, that's really what we've been focused on. I hope that answers your question, and I imagine others on the panel have some reflections on that too.
Thank you. We're going to move on to the next question for Dr. Frontera. What interventions are being tested for long COVID? Which are most effective? And similar and along the same lines, what can be done to prevent long COVID?
Okay, good questions, multi-part. I will say that the NIH put out a call for clinical trials last May, and the clinical trials center site, coordinating site has been named. It's at Duke. And so we are anticipating that clinical trials will start up shortly, and I can only surmise what might be studied because I don't think the awards have been announced yet. And so currently things that we're using therapeutically are really symptom-based, and at least our data, which is only in 122 patients, so a small cohort, suggests that they're still pretty effective, even what clinicians are doing based on symptoms at this time. And certainly for post-COVID headache, We often extrapolate for what we do for post-traumatic brain injury headache, and it seems to be effective based on some studies that are out there using amitriptyline or nortriptyline or tricyclics in these folks, which may not be options for older people, but certainly do seem to help younger folks with post-COVID headache. With post-COVID cognitive issues, Dr. Morley mentioned some potential cognitive exercises that folks might use, but again, very limited data in the context of COVID for this. I think there's a lot of interest. If I'm going to speculate, I think the first trial might be something looking at Paxlovid in terms of this concept of looking at viral reservoirs and eliminating viral reservoirs as they may contribute to chronic inflammation and post-COVID symptoms. But again, that's just my guess. And I don't know which studies are going to be started soon, but the good news is there's a lot of money put towards it by NIH. And I think we'll start to have answers rolling in, which people desperately are waiting for.
Thank you so much. And just as a follow-up, I know that you mentioned that the treatment might not be good for older adults. Could you elaborate just a bit on that? And then
I mean, so the tricyclic drugs, which is a really old group of drugs that were typically used for depression, are really great for migraine-type headaches and post-traumatic brain injury headaches. And there's a literature using them for post-COVID headaches, but they can have this side effect of actually increasing confusion, urinary retention. They can cause heart EKG side effects, so which is particularly notable in older folks. So we may not be able to necessarily extrapolate all the data we have in post-COVID populations to older populations.
So very important to know. And also I'll just put a plug in for that is why it's very important to have older adults participate in clinical trials. Okay, moving on to the next question.
Nina, can I just add one thing? The literature has suggested that vaccines decrease the amount of long COVID. It's not absolute, but there is enough data there. There has been very little data or none that I know of looking at people who've had COVID, get long COVID, getting vaccines. But it actually makes a lot of sense that you really want to try and get rid of the COVID that's left in the body causing long COVID. And it seems to me that the things that we do really badly at the moment are paying attention to vaccines and making sure that everybody gets vaccinated. It's the same thing with flu. If you don't get it, the years that people don't get flu or the flu vaccine doesn't work well, we have tremendous problems with older people. I think we have to pay more attention to those. And it terrifies me when I hear large amounts of money being given out to study things. I recognize that means it will be all unique, wonderful, marvelous things, which I spent my life here studying as well. And we won't put nearly enough money into the simple things. Just a thought for the people out there who might be doing this.
So the take-home message is vaccines in this context are almost always the right answer. Over.
Thank you, Peter. I wish CDC would say it a little louder.
Okay. Next question for Dr. Briss, related to some of the topics that you covered. This person said, without having a crystal ball, what types of adverse health outcomes do you anticipate for older adults as a result of the decline in healthcare usage during the pandemic?
Well, so that's a great question. We don't know about outcomes yet, but we do know that there have been gaps in care in hypertension management and diabetes management and cancer screening and a long list of other things. And so the bottom line is that we have a lot of catching up to do, and it's time to get busy. Over.
Thank you so much. Next question for Dr. Martine. What interventions have been undertaken to help alleviate the negative effects of the pandemic across older adult groups and particularly among underserved groups?
Yeah, so I think it depends on the type of intervention that people are thinking about. So I would say, some of the biggest ones, I would say, as were mentioned before, of minimize the negative impact of the pandemic is having vaccines available, right? And making those accessible to people. Like if we are able to get vaccinated and, understanding that masks are helpful, that we were not that sure when all of this began, if you might recall, right, that this was not put forward in that way. Those are the type of interventions at a global level that can help us, less people get sick, less people get seriously sick, and be able to engage in a different way and lead our lives in the ways that we would like to. So that's what I would say is kind of one broad sense of interventions. I think there's been a host of different things that people have tried at a small level as well and in different groups. Of course, I'm not aware of absolutely all of them, but there are programs, for example, I know that we're at my institution and trying to connect older adults in different ways, having programs to digitalize the population and the older adult population to have them get access to not only connect socially with other people, but access to care and so forth. So those are just some of the few that come to mind at this point. And I know of smaller types of interventions as well, but I'm sure others in the panel might have some other things they might want to add as well.
Well, I did notice in your presentation that one of the positive impacts that you commented on and that you heard from your respondents was that a lot of them were doing volunteer work in their communities. And so I know there are efforts for people from within the community to help with education and helping to explain what the vaccine does and what it doesn't do and what it, how it can help to try to raise awareness of that.
Yeah, that's a very good point. And again, all sort of different things. I think in different countries as well have been in different ways. So I can speak to some of the other media I see in some Latin American countries and from these interventions at a global level of like, let's get outside, be in open spaces, be in nature, all of these things that maybe people didn't used to do as much, and recognizing the positive impact of that. And that sense, we're all in this together. We're all living through this historical time. Right? We're in it together. And so how can we support each other to move forward? And I think just having that message cut across segments of the population can be very powerful. I've seen that happen in other spaces. Maybe not so much here, maybe in the US, or maybe in some groups, but that can be very powerful as well. That sense of
agree.
Yeah, I think we also need to push the other part of prevention, which is masks. This is not over. If we want to keep on getting it, it's going to keep on doing what flu does, which is change itself a little bit. We've got to be much more aware that people need to mask, at least when they're out in public indoors. And if people don't want to do that, it's not going to get better. So we can be like Singapore, which really knows how to do things like this, or like the United States or Brazil. Brazil is actually worse than the United States. I've been there a number of times, and they have as little interest in doing any of this as we have in the States, I think. But we really do need to push the possibility that we should keep on preventing until the amount in the community is very low. At the moment, we're nowhere close to having a low enough amount to say that prevention is not worthwhile doing, at least in my, I think, scientific opinion, because that's what the science says as well.
Okay, and we have a question that was asked for Dr. Frontera, but Dr. Noble, if you would like to also answer. It was, can COVID cause dementia outright, or is it more the case that it causes the exacerbation of dementia?
So, I want to say we definitely do not know the answer to that yet. So I would, not want people to become overly alarmed. It's certainly an area of research, but I would not say at this point that COVID overtly causes dementia. I think that certainly a lot of us are looking into it, but I would hesitate to make that proclamation. And I'll let Jamie answer the part about worsening dementia.
Yeah, I would agree with Dr. Frontera that, in my clinical practice, I've not only seen people get worse after having COVID if they already have dementia, but I've actually seen people bounce back and with not really an appreciable change in their overall trajectory, which was happening in the background. And it's for this reason that we really, need to work with the largest cohorts possible to understand what are the differences between those two people who seem to have the same disease but have very different trajectories. To the point of whether or not it can cause it, We've actually undertaken at our center a neuropathological study of people who had initially presented with COVID and came to pass because of their illness. And for the most part, the main changes that are seen under the microscope do not suggest that there's a strong viral infection of the brain cells, but maybe more inflammation and the small vessel strokes that we've come to recognize. So in and of itself, brain changes are not that obvious with the exception of maybe some microvascular changes. We're not seeing as though suddenly somebody has a blossoming of Alzheimer's changes under the microscope. And to some extent, that reflects what we know of Alzheimer's disease, and that it takes years for people to develop changes microscopically of Alzheimer's disease that eventually lead to the clinical syndrome that we see of forgetting or other cognitive impairment. So it's a great question. We don't have a full answer, but I agree with Dr. Frontera.
And along those same lines, somebody else asked, how do the brain biomarkers translate to risk of death? So you kind of answered on that, but do you want to more directly address that?
Yeah, I mean, in our cohort, people with higher markers, neurodegenerative markers, also had higher rates of death, but that's not adjusting for all of their factors. And it's not surprising that people who are seriously ill, have low oxygen levels, are going to, their brains starve for oxygen. Of course, there's going to be some impact there. And so it's not surprising that those things go together. It's not directly causal, meaning that that brain injury led to that person's death. But, it is a marker that these folks were really sick and that something is indeed happening to their brain. It's not just that they have low oxygen levels and they're dying in hospital because of respiratory problems. There's neurological impact also.
Yeah, we recently published that basically neurofilament light chain levels in people 50 to 65, when they're elevated, is associated with earlier deaths. And we saw today COVID pushes those up. It's saying that if there's damage to parts of the tissue, it's more likely to accelerate death. And I think we have to recognize that that is most likely the outcome. We haven't looked carefully to see what's happening to deaths, but if we look, we've dropped the age of death in America fairly dramatically over the last 2 years. And we can say that that occurred not because of COVID, but because of something else. But it's either acute COVID, but I think it's most probably a combination. And I think we need to be very aware of that as we go forward.
Yeah. And there's another related question. I'm not sure who's best to answer this one, but does COVID or long COVID cause faster aging in general? Have any studies looked at whether it increases biological age? Anyone want to take that one?
There are no direct studies that I'm aware of, but again, the increase in NFL, which goes along with aging, would be one of those. Increased cytokines tend to increase the rate of aging, at least in animals. We've done a lot of studies with Alzheimer model Alzheimer's showing that that's the case. So I think we should assume that it's true. In our nursing home staff, we're finding a large number of staff who can't come back to work a year later. They're still fatigued, and they finish up retiring. So fundamentally, I think that it most probably does, but those are studies that need to be done, and they are long-term studies. You're not going to get the answer in 6 months. It's going to take years to understand whether we're accelerating aging, whether or not people who've had COVID are going to die with 2-4 years later, even if they don't have long COVID. What the long outcomes are going to be. And I think we need to pay a lot of attention to that. That's my opinion. Again, we don't have any science to back it at the moment.
Okay, thank you all very much. It shows on my clock as noon Eastern, and that is our end time. So I want to thank everyone, the speakers, the attendees, and the future watchers of our webinar. Hope that you all stay tuned for updates about our upcoming Focus on Aging Federal Partners webinars. And there's the link on the screen to be able to keep up. And again, thank you all very, very much. Take care.
Thank you.